Hey everyone, let's go and get started with obstetrics. This is really a rapid review of everything you need to know, really of kind of a overview, high-level thing for obstetrics, jam-packed with lots of high-yield points of all the things that you just can't skip over if you're doing a review. This is great if you're going over you right before your exam, or you just want to really have a quick review so you can use this to fill in all the things you need to know. Let's go ahead and get started. My name is Dr. Kendall Wyatt. I am the Medical Content Director here at Picmonic. So if you've never heard of Picmonic, what we do is we take all of the medical facts you need to know and we turn them into fun picture mnemonics that you can go in, check out. You can check it out for free. I recommend it, but in full disclosure, I do work for Picmonic. So when you need to learn something like the medication oxytocin for OB, then you can learn that by remembering the octopus toe. There's tons of different topics for nursing students, medical students, lots of different things. You can go check it out. If you're just doing this a review, if you're getting ready to learn for your NCLEX, I recommend doing lab values, electrolytes, and then review of drugs. So there's all those really high yield side effects you need to know. Now, what are we going to go over today? So today we're actually going over pregnancy. Shocker, right? So we're going to go over pregnancy. We're going to go a little bit over labor, delivery, the stages of pregnancy, and then some complications of labor that are super high yield, and then just some assessments and then a review. This is about an hour long, but it's about the most rapid, high-yield review of an entire semester of OB that I could possibly get for you. But it's most of the highest yield stuff. It's a really great review, but if you have any questions, you can always type them in. And if I don't get to it, we'll get to it at the very end. And we'll review them all the way at the very end. So let's go ahead and get started with this. I'm not going to go over this example that I use a lot, but I really like to use the fish tank model for all the body systems and how they all interact. So I'm not going to go into the details of all this, but if you check out any of the other webinars on any of the other body systems, you'll learn about how we talk about a fish tank and a pipe carries pipes carry water in a fish tank, but in the body they're just like another fish tank. It all works as part of an ecosystem, and it's going to move blood around in the veins and arteries just like the pipes. So it all works together, and everything you need to know works together in a beautiful body system, so that way you can keep homeostasis. Excuse me. Now let's jump right into to pregnancy. Now, excuse me. We're going to go over a couple of different things. We're going to go over Naegele's rule, gravity and parity. We're going to go over those signs of pregnancy, and that's really high yield, so make sure you pay attention there. Trimesters and what we're looking on as far as the discomforts and the stages of pregnancy, and all those key weeks that you really need to know, because there's all kinds of questions about just weeks of everything. Oh my goodness. So I do an individual topic, individual by itself, the ovulatory hormones. I find a lot of people really get this confused. But you can remember that if we know that in a normal cycle, a normal woman's cycle, right? We have the follicular phase and the luteal phase. So the follicular phase, if we imagine a perfect cycle is 28 days long, well, which one of these is fixed? And that is the luteal cycle. So it's fixed. Lute means to cover, so that means we're covering and building a cover to protect a potential baby that might be there. The follicular phase is essentially the follicle itself, and where's the follicle? The follicle is a part of coming from the ovary, and that the egg essentially fertilizing, breaking loose, so that fimbriae, the follicle, can grab it and then take that at ovulation, take that egg so that it can be fertilized. I usually, I could spend 20 minutes just talking about this individually. I'm not going to go into big things, but you just need to, there is really a couple of important things to remember. The luteal phase is a fixed number of days, and the follicular phase is actually the phase that can change in range and is affected by all those reproductive disorders like polycystic ovarian syndrome, PCOS, and hormones and all the other things, or a lack of hormones, that we're trying to get ovulation. And ovulation is when that egg breaks free from the ovary and can then be picked up by the fimbriae and go down the fallopian tube to be fertilized. So when we talk about a couple of disorders, we're going to talk about ectopic pregnancy and things like that in a little bit. Now, one of the most common questions, or the things you really have to be able to calculate, and if you don't do OB-GYN and you don't want to be an OB nurse or an OB person, OB is not my favorite topic. I'll be honest, but it's not my complete least favorite. I think biochemistry is probably definitely a lesser favorite of mine. Let me just fix one more thing here on my screen. There we go. So, but you've got to know Naegele's rule. So how do we calculate Nagel's rule? What is it? Well, it's going to give you the estimated delivery date. It's going to give you that estimated gestational age. And how do we calculate? How do we calculate the expected day of birth? It's a really common question, and it's just a simple 1, 2, 3 step process. So the first thing you want to do is you've got to have that first day of their last menstrual period. So the day that they started their menses, that first day. So what is the day? Most women remember that day. Most of them are somewhat cyclic, but they definitely probably remember within the last few weeks or the last month of when the last one was, because most times, a lot of times, especially males, I think, they say, well, why did how could you easily remember a random day? And that's because, well, if you miss it, that's serious. So you remember when the last one was, so you know how far you went. Some women are irregular and things like that. So most people usually know their first day of their last menstrual period. The second step you want to do is then take that the first day, and if we say that first day, for the sake of making an easy calculation, is January 1st, 2000. Now, a lot of people thought January 1st, 2000 wasn't going to exist. I remember being 1999 on New Year's Eve. It was like the big Y2K thing. So I think this is a funny day, but maybe I'm just aging myself a little bit there. But so if we take January 1st, 2000, that's the first day of the last menstrual period for this particular person we're calculating. The second step we want to do is we want to calculate back 3 months. So we know January, so then we can go January, we can count back to December 1st, we can count back November 1st, and we can count back October 1st. So that's going to be October 1st of 1999. That's back 3 months in time. Okay, but just back 3 months is all you need to be able to do. So we counted backwards 3 months, and that's going to give us October, right? So we've changed just the month there. So we've counted back 3 months to October, and then the only thing we need to do next is then add 7 days to that particular date that we have there. So 1, 3, 7. 3 steps, 1, 3, 7, add 7 days, which is going to give us an estimated delivery date by Nagel's rule of October 8th of the year 2000. So let's just run through that really quick again. So you start with that first day, the last menstrual period. We're going to say that's January 1st of 2000. You count back just 3 months. So you're going to move the months back. You're going to move that back 3 months to December, November, October. So you've moved it back to October, and then you need to add 7 days to the number. So then that's going to add 7 days, giving us this October 8th, 2000. So if the last menstrual period was here, that's going to be October 8th. Super common question. It's always going to pretty much be like this. Yes, there are variations in cycle, but this is the formula that you need to use, and definitely really need to double check. So how do we, I always put this in here just to make a note, so make sure I mention it too. But what you want to make sure you do is just make sure that the date you're using is logical. Oh, someone even wrote in a question about it. So make sure that date's actually in the future, right? So you can't have the baby if it's in 1999 because you're just counting back 3 months, right? So you're counting back 3 months on the time. So January 1st, we're just going to count back months because ideally what we're doing is from the last menstrual period of January 1st, 2000, we're calculating forward. We're actually calculating a date forward. So you count the first day, you count back 3 months, and then you add 7 days. And that's why a lot of people get confused with this. But if you 137, and then you just remember to do that logic check at the end. Logic check. Okay, yes, this is in the future, not in the year previous, because sometimes dates are going to be a lot of this time going across a year, and that's where you're going to maybe have a mistake. But don't mix that up. That's an easy way to double check yourself. Is it in the future? Yes, then you got it. So the next thing, and if you have trouble with Nagel's rule, you're going to see a lot of questions on it if you haven't quite got to OB, but very high likelihood you're going to get a question about it. So gravity and parity. Now this is something you just have to understand at all aspects, at all times. You really need to understand gravity and parity. So gravity or gravita or gravity is essentially, gravita is the number of pregnancies. So the number of pregnancies that a woman has ever had. So a number of pregnancies a woman has ever had. And the number of pregnancies you've ever had is going to be gravity. So I always remember G comes in the alphabet before P. So gravity, GP, is always going to be first. So that's a number of pregnancies because you got to get pregnant before you can have parity or para, which is the number of pregnancies that exist beyond 20 weeks. And that's where we can really think about, those are going to be, parity are going to then be essentially potentially live births. So those are things that are going to be viable. Because what in 20 weeks, what's the important thing that happens in 20 weeks? Well, that's where we know we have lung development, and lungs are the things that the last thing is going to be a problem for being able to have a sustainable birth because of surfactant and what we call the lecithin sphingomyelin ratio, that LS ratio, to be able to get it. So we can stimulate the lungs a little bit, but before 20 weeks, it's very difficult to have a viable living child before 20 weeks. So parity is pregnancies that really go beyond 20 weeks. Now, you can break this out beyond that, and there's all things that count in parity. All these different things that count as far as part of parity. And that's what we call TPAL, so TPAL. So you may see this, especially if you do OB, you're going to need to know each one of these particular things. But they pretty much are, I think they're self-explanatory. I just remember TPAL. And I remember T is full term, T for term. Preterm that means they're early, so preterm, preterm. Preterm is going to be basically before 37 weeks, because 37 weeks is considered a term pregnancy. We're going to talk more about the weeks in just a second. But then abortions are not abortions. That abortion can be a natural abortion or an elective abortion. That's really important. And what is an abortion? That's, it can be pretty much before 20 weeks is an abortion. Then we have the number of living children that essentially are born alive. The child could die at 7 days, but it's still a living child. It still was living at birth, and that's where we see the different numbers. Now, most commonly, in general terms of everything, you're just going to see gravity and parity. And what you can then know that is that means that gravity is they've got pregnant so many times, and parity is how many essentially births that they've given. That's really the simplified version, but just keep in mind that there is the TPAL, so you may be given a little bit more complex question. So if you just thought about gravity as the number of actual pregnancies, and the parity is the number of births, then that's an easier, more simplified version to think of. It's just to kind of keep things rolling in your head, but understand that it does go a little bit more complex. So as we go into this, the next thing is we're getting a few random questions, and we'll get to most of these probably at the end since they're a little off timing. But the next thing is signs of pregnancy. What are the signs of pregnancy? And this is, if there's one thing that I guarantee you're going to get questions on, it's going to be a lot of these things right here. And those are going to be the signs of pregnancy. So what are the signs of pregnancy? Well, we're going to have presumptive signs, probable signs, and positive signs. And these three buckets of things are super important that you know them. There are the presumptive signs, probable signs, and positive signs. And you really need to know the difference of these. So let's start with presumptive signs. So presumptive mean presumed. That means things that we think there's a pregnancy, right? Maybe I think I might be pregnant. I think I might be pregnant if I miss my period. I have amenorrhea. I may be pregnant. Does that mean I'm actually pregnant? No, it doesn't. You're going to see a lot of questions about that. They're going to see breast changes and breast tenderness. When you have nausea and vomiting in that first trimester early on, because the nausea and vomiting usually happens because of increases in hormones. Specifically, HCG it causes a lot of that nausea and vomiting. And you can have urinary frequency and fatigue. But I could pretty much point a lot of these to a lot of different things of reasons why you could miss your period, reasons why you may be having a lot of urinary frequency, and even breast changes, so breast tenderness, or things like that can happen just because of a lot of other things like polycystic ovarian syndrome or hormonal imbalances. And quickening is just feelings, these feelings of, that you feel like you're pregnant, but it could just be gas. It's presumptive. It's not a guarantee. So the next thing is probable. Now, probable signs of pregnancy you're probably pregnant, but it's not guaranteed. and it's still not that does not mean that the patient is pregnant. And here's where you're going to see these specifically. The one that you're going to see the most is a positive positive urine pregnancy test. So a positive urine pregnancy test does not mean that you are in fact pregnant. It does not. It means you're probably pregnant. And I know presuming and probable, it sounds like they're like really side by side, but what you're mostly going to get are all these signs of all these two lists of things, and then you're going to ask you, the patient wants to know, are they pregnant? Yes or no, and the answer is probably, possibly, but it's not a confirmed pregnancy, and there's only a few things to really confirm a pregnancy. I should have clarified this one here for pregnant. I say positive pregnancy tests. I mean positive pregnancy urine tests. That's really important. Now, there's a couple things with the signs. These signs. I find these very confusing. To memorize, but these signs are Goodell sign, Chadwick sign, and Heger sign. And I usually try to remember that these three signs are all probable signs, but they all have to do with the cervix itself. So Goodell sign is essentially, this is a very weird way to explain to talk about it, but Goodell sign is a velvety. It's a softening of the cervix, but it makes the cervix appear velvety. Chadwick sign, I always think of Chadwick, and then same in our Picmonic, we have like a purple chapstick. Chadwick sign is essentially an increase in blood flow to the cervix, so then it becomes a very bluish purpley collar, so it's a collar change. Heger sign is cervical softening that can be actually appreciated on an exam. So you're actually going to insert two fingers in. You're going to apply manual pressure on the abdomen and be able to feel that the cervix is soft. It's not something we do routinely. It's something we used to do before we had urine pregnancy tests, so we didn't require these exams, these vaginal exams, just to anticipate the fact that you may be pregnant. Of course, Braxton's Hicks contractions are probable signs, but those are not, positive. And ballottement. Somebody asked what ballottement is. Of course, ballottement is essentially if you were to apply pressure on the cervix, you'd push up on it. What's going to happen is the cervix is going to basically come up and come back down, kind of like a blob. Ballottement is how I remember it. It's kind of going to come back up and retract back down, and that's because of that the cervical enlargement, and it's because it is. Because of the increased blood flow, because it's getting enlarged, because you're probably pregnant. Just to review again, Goodell sign is cervical softening, but specifically it's a velvety appearance of the cervix. But Heger sign is actually you're going to insert two fingers, and is actually going to feel cervical softening when you push down on the abdomen. So, if you have the abdomen up here, two fingers, you're going to push down the abdomen, you're going to actually feel a softening of the cervix. And that's a palpable sign. Goodell sign would be an inspection sign. You're going to see this velvety appearance. So I always remember that Goodell means it's going to look good and velvety, because velvety would feel, would look very plush, I guess. Kind of a weird way to explain it or remember it, but it works. So that's how I explain it. Now, positive signs are the things you've really got to, you can take these and you can really move these to the side and know that these are positive signs. So these are the only things that are positive signs. If you have an ultrasound where you visualize a fetus in there, that's a positive pregnancy. If you take an x-ray and you can see a positive a fetus in there, that's a positive sign. Or if you can get a fetal heart rate, that's a positive sign. Or if you can actually palpate fetal movements, because gas, you're not going to be able to feel, you're not going to be able to palpate fetal movements. If somebody was just bloated and had a lot of gas. And this is really important. One thing's really important here is, do we do an x-ray as a pregnancy test? Absolutely not. We don't do a x-ray for a pregnancy test, because X-rays are very damaging to a pregnant, very young developing fetus. But of course, the big one is ultrasound, and you actually visualize that. You probably then get the fetal heart rate with an ultrasound, but you can actually auscultate a fetal heart rate as well. So lots of things on here. Barbara says, hold on one second. forgot to turn my phone off. Barbara says, why would we uh, why do we include X-ray here as a positive sign? Because sometimes it's found incidentally. We don't do it as, these are not tests of pregnancy. These are not the tests that you do for pregnancy. These are positive signs. These count as positive signs. So there's the long way if you visualize, you visualize a fetus in there on an exam. So we talk about trimesters. Trimesters are really important to kind of know some big points about them. We've got obviously trimester. There are three pregnancy. Several people ask about the blood work for indicating pregnancy. So we don't necessarily say that that's a positive sign. All the pregnancy tests are probable signs, but specifically the urine test is the one that usually is the commonly tested one. So maybe I didn't clarify that. But the urine tests are the one you're always going to get that test. But any test done, any blood test could be physically wrong. But that's what you're going to then get you to do an ultrasound to get a confirmed positive test. So you always do an ultrasound. That's this gold standard. However, the urine test is not a positive. Not a positive. It's only probable. So when we talk about trimesters, we've got first, second, third trimester. You really got to know the three trimesters, and there's a lot of big points. So each one, the next few slides, all go along with these same trimesters with each one of these. So when we talk about trimesters, essentially, if we think about, we divide everything up in weeks, we know the first trimester is going to be a lot of the, especially in those first 8 weeks, a lot of the neural development. That's a lot of when we have a lot of those teratogenic drugs that are really going to cause a lot of problems, are going to be in the first trimester. Alcohol as well is a big one. Lots of things that we worry about are usually in the first 8 weeks. And when we have women who they have a missed period, often they don't get a positive test quick enough to be able to kind of make sure that they're maybe not drinking or abstaining from other things or stop their medication, specifically seizure medications. Lots of medications that work on the brain cause a lot of they're very often very teratogenic. The second trimester is the fetus getting lots of growing in size and whatnot, and that's where we're going to see our 13 to 28 weeks. So 0 to 12, 13 to 28. Now, inside the second trimester, we've got 20 weeks, and 20 weeks is the big number to know that that is the minimum age to have that viable delivery, minimum age. That's all developed around lung development because of lack of surfactant, because the lungs can't essentially expand and collapse appropriately. So the next one is the third trimester, and of course that's 29 to 40 weeks. And a lot of people always say, well, everybody doesn't go to 40 weeks, and that's absolutely true, but that's essentially 37 weeks is considered a term pregnancy, 37 to 40. Once we go over 40, then it's a post-term pregnancy, and that's really that's where we always see we often see induction of labor because we risk of having a fetus that's too large. Let me just see what we got here. That's for sure. So when we think about the second trimester, here we've got again this 20 weeks. 20 weeks in the second trimester. It's the really important number you got to be able to know for several different reasons. That's where we're not, if you're going to have, it's the cutoff date as far as using the term abortion, or for, basically the ability for this fetus to survive on its own. As far as also calling it a spontaneous abortion is the term. If it's beyond that date, it would be considered a stillbirth. If the body essentially, aborted the fetus itself, it's considered a stillbirth because it could be a viable fetus after 20 weeks. The other really important thing is to measure the fundus size. Fundal measurement is one thing that's really important. And basically, I don't have a diagram really to be able to do this, and I don't have a good belly to be able to show it off on this video. But basically, when you palpate the fundus, the fundus is going to be at the umbilicus. So basically, at the belly button, you're going to be able to palpate. You're going to push in on that and feel the top of the fundus right here, right at the umbilicus. And if you were to measure it, then you were to measure from there down. to the symphysis pubis than you would also be getting a length of about 20 centimeters. So it's 20 weeks, 20 centimeters, fundus of the umbilicus. That's also the abortion cutoff date. So there's a lot of important things around 20 weeks. Also with that, we also see that's when we usually see normal quickening. So they should be feeling fetal movements by 20 weeks. It's expected at 20 weeks that they could feel fetal movements. And after 20 weeks, if they don't have fetal movements, then we worry. I mean, it's not until after 20 weeks that we would worry if they can't feel the fetus kicking. Sorry, my mouth gets super dry. So back in the first semester, we already talked about all these, but in the first semester, that's where you've got your 8 weeks. That's where the heartbeat essentially is going to be able to start at 8 weeks. You should be able to hear the heartbeat. And then we've got those signs are all in the first trimester. That Goodell sign, Chadwick sign, Hedwig sign. But that's why all of those are Hager sign. That's where we're going to see all those in that beginning first trimester, but that's why they're probable signs of pregnancy for Goodell sign, Chadwick sign, Hedwig sign. Auscultating a fetal heartbeat, positive sign. That's definitely positive that it's positive pregnancy. And of course, at 32 weeks, beyond 32 weeks, this is where we essentially, we believe it's proven essentially after 32 weeks, the lungs should be completely matured. So after 32 weeks, pretty much okay to deliver, still could be premature, but the lungs don't need steroids to be able to get fetal maturity. They aren't going to need critical care per se as much. Yes, I know there are examples where you saw a person that needed it. That doesn't mean it's needed all the time. But essentially, a birth beyond 32 weeks is much less risk of having severe neonatal respiratory distress syndrome. It's at less risk. That doesn't mean it's going to happen because 32 weeks usually are where we see this fetal lung maturity. And maturity means that the sphingomyelin lecithin ratio is above 2, so that means they should have that's the perfect amount of surfactant to be able to create that expansion and collapse, and the lungs don't stick together because of a lack of surfactant. But also, the fundus should be at the xiphoid. Now, it's important to know once you go past 20 weeks, you need to be able to measure the fundal height beyond 20 weeks. So if you know that the fundus is at the umbilicus at 20 weeks, essentially every week beyond there, it's about 1 centimeter more every single week. So if you were at 28 weeks, you should be 28 centimeters or 8 centimeters beyond at 20. So basically from the symphysis pubis up to the 28 centimeters, which would be above the umbilicus. But these are just common terms that you just kind of got to know, because we use them all the time, and they're very commonly tested. Now, along with sizing, this is super important to be able to know the sizing and the weight if this fetus were delivered. At 8 weeks, it's literally a 2-gram fetus, 2 grams. So 2 grams, that's very, very, very small. Super tiny 2 grams is literally nothing. 200 grams at 20 weeks, 200 to 400, of course. And then, of course, 32 weeks, we're looking at about 1,800 to 2,200 grams. So what is a normal birth weight? If at birth, what we consider a normal birth weight? Super high yield question that we see all the time. That we see all the time is the normal birth weight. What's a normal birth weight? So a normal birth weight is going to be above 3,200 grams, or about 7 pounds. But we always measure in grams. You need to know the grams. Don't remember the pounds. It's handy to know when you're talking to your friends, but make sure you know the grams. So we'll see a normal birth weight is above 3,200 grams. So if you get below 3,200 or below 3,000, you're going to call that an underweight fetus. So super important. So here we've got just more things, signs and symptoms you're going to see inside of the first trimester. If we're talking about the first trimester again, we're going to see those signs and symptoms, those physical exam findings. But the patients are going to experience these signs and symptoms. You're going to see that breast tenderness again, which is a presumptive sign, nausea or urinary urgency. And again, remember that nausea is caused by HCG. So there is something called hyperemesis gravidarum, and essentially that is excessive nausea and vomiting I mean, literally, like excessive, crazy amounts of nausea and vomiting for in usually seen in the first trimester. So that nausea and vomiting, because of the HCG surge in the beginning, in the first trimester, it usually drops off and tailors off and goes back down. And that's why nausea and vomiting doesn't usually persist throughout the whole pregnancy. But we also see leukorrhea. So this is just just basically leuc means white. So usually a white discharge from the vaginal area, and that's fine. It's usually just a mucus. Because as the cervical mucus itself will thicken and create a like a cervical mucus plug essentially, and that's where you can get some leukorrhea. And you can also there's lots of other things that go along with testing the cervical mucus to be able to test the thickness and basically how stringing it is. We're not going to go into any of those things. I think those are much more for an OB specialist. But you do see another weird one that's sometimes thrown into some select all that apply questions is ptyalism. And that's just literally just excessive salivation. So it's just sometimes happens in some women. So we got lots of our Picmonic characters in here from our Luke character with the little cookies that you can remember the name of. Now, second trimester, here are where we see a lot of some important signs and symptoms that need managed very often. So we can see a lot of these second trimester. Remember, if we thought back to what happens in the second trimester, that's where you're really gaining a lot of size. So you're gaining a lot of size, and you could end up with two things, big ones: supine hypotension and constipation. So big ones: supine hypotension and constipation. Why do we have supine hypotension and constipation? Well, if we think about where that fetus essentially is, the fetus is sitting right in the abdomen there, and it's when you lie back, it can apply pressure on the in the vena cava and the aorta, but it's going to apply on the vessels back there and can cause blood pressure drops. Because what happens is your blood pressure drops essentially anytime an artery is feeling constricted. So it's the same reason if you were to give somebody a chokehold and you put your hands around on their vagal the vagal response, but if you put pressure on the carotid arteries, those arteries are going to sense a high pressure and they're going to say, "Whoa, we're blowing too much pressure. Let's relax." So they'll drop the blood pressure. But what happens is that's only in one area, and it's not because of high blood pressure. It's because of the pregnancy. Constipation is a lot of the same thing. You're going to have there's the Douglas pouch there, kind of where there's in behind the uterus, and the uterus is going to be pressing back. And what happens is it presses on the colon, and when there's just not enough space in there, what happens is you can often have constipation. So a good high fiber diet, regular voiding, things like that are really important. The bladder is usually affected first, but that usually happens in the first trimester. You can see a lot of the bladder symptoms. They can persist to the second trimester as well. So, they have to go to the bathroom very often and whatnot. Food cravings, yes, sure. But heartburn also because of the pressure and the pressure in the abdomen and when you do lie supine. So we also see varicose veins. Varicose veins because of pressure also. But pressure buildup because the blood flow can't drain from the veins, from the legs very well into the vena cava because of that extra pressure in the vena cava. So what happens with some women is that that extra pressure causes a failure of the valves of the veins because of the back pressure, and failure of those valves in the veins causes varicose veins in some women. Every woman don't get it, but some women get severe varicose veins from being pregnant. Now, third trimester things, a couple things we see here: shortness of breath, again, just because of fatigue and whatnot. You're going to see urinary frequency come in with a kind of a vengeance here, and then cramping and essentially just edema. And that's because of even more of that failure of drainage of fluid, lymph fluid, as well as the venous drainage not draining as well. And also because, you increase your total body fluid in pregnancy a lot. So if you increase your total body fluid, what happens is then you also end up with a transient anemia because you're increasing total body fluid, total body water, total body plasma, but you're not increasing the number of RBCs at the same rate. So you can also see, and that's why you end up with also edema and these other things, because you need more body fluid. So that's also important. And of course, to be able to combat all of these ankle edema and the extra fluid, the cardiac output increases in pregnancy. So just a kind of tying in concepts here to think about all of it. Now, the next thing I want to talk about, just labor and delivery, a couple things. Inducing labor, accelerations and decelerations, super high yield, as well as placental implantation abnormalities. And then I'll just mention prolapse umbilical cord, because it's important to know a couple of important points with that as well. So let's get started here. Here's an example of accelerations and decelerations. Now, these are super important that you know these, and there's a really common mnemonic out there that you may have used already, and we've turned it into our Picmonic, and that is veal chop. So you need to know veal chop, and what's going to happen is you're going to be given some type of scenario where they're going to tell you that they have accelerations, they have decelerations, and they're going to ask you, what is the problem? It's out there on every single exam. You've just got to know it. Now, I hope that you learn what it actually looks like, and I'm going to show you a couple of that, but it's going to give you what it is, and they're going to ask you what's going on. So here's our veal chop. So we get a little baby cow with a little chop sign. And what happens is, when you think about veal is variable, early, and then just, oops, sorry, I got a foot cramp. Let me just turn this on here. So let me turn on all the little layers, and then I'll go through it. That way I'm not trying to do two things at once. So here's our actual Picmonics. This is kind of how our system works, but it guides you through it. So veal chop. Veal is the types of accelerations or decelerations. So decelerations are the things that are different ones, and then there are just accelerations. So there's variable decelerations, early, so E early. Then there's just accelerations, and then there's L for late decelerations. So all the ones that are different types of ones are decelerations. Decelerations are derogatory. They're bad. Decelerations are derogatory and they're bad. That's why there's 3 different types, because we need to show what type they are. Accelerations are great. They're good. It's always good when your heart rate goes up a little bit, right? Well, maybe that's not a good example, but it's okay. That's a good thing. So let's think about each one of these. So here we've got our variable decelerations, and that essentially in the image here, as part of the bottom, we've actually got the little dotted lines, and these are actually the dotted lines here go along with what the fetal heart rate is, and then the uterine contraction is on the bottom of a wave. So if you actually go and look at one of these, an actual chart of this, if it's charted out, you'll actually see what the big curve at the bottom is the uterine contraction being measured, and then at the top is the fetal heart rate itself. So variable decelerations or decelerations that are happening all over the place, there's no regular pattern to them. As they correlate to the uterine contraction, it's most likely cord compression. Could be for several different reasons, but usually maybe an inverted fetus or a foot first, a breech presentation, different things. Early decelerations, so that means that the deceleration is going to happen almost at the exact same time as the uterine contraction. What should happen is the fetal heart rate should essentially go up after the uterine contraction, because then the baby is going to be accelerating the heart rate after the uterine contraction. That's essentially what should be happening, but that is it's going to happen at the same time as the uterine contraction, or essentially at the same time as the uterine contraction, and that's a good thing because that's normal blood flow. So early decelerations are basically decelerations that are going to be happening at the same time or earlier, before or during the uterine contraction itself. And that's usually E is early deceleration. That's because of head compression itself. So the head is being compressed in some way. Could be because of polyhydramnios, oligohydramnios, different reasons, or a small, basically the vaginal opening and everything isn't large enough for the fetus. Accelerations accelerations are okay, and late decelerations are placental insufficiency. So placental insufficiency means not enough fluid usually. That means not enough blood flow. That means the placenta isn't getting enough blood flow, either because it's already detached in something like placenta previa or placenta abruptiae. So it's basically hemorrhaging, or there's a problem, placental insufficiency. So veal chop, you can write it down. You need to remember all these. Probably one of the most high yield things, as far as you will get a question on this, as far as the veal chop and picking which one. Guarantee it. Now, another really common select all that apply question that's out there, or something that you'll probably get, are contraindications for induction of labor. So labor itself is fine, normal labor, but then there's very specific contraindications for induction of labor. So basically, we're not going to induce vaginal labor, on any patient with any kind of placental abnormality. I think that's an easy one. Or somebody who's in a transverse fetal position. So one of the things you're going to do is you're going to palpate, maybe even do an ultrasound, and you're going to see the position of the fetus. Remember, it comes out head first. And if it's transverse, that's a no-no, because the baby can't fold in half to come out. Now, that doesn't mean that they may not do the maneuver to actually maneuver the baby into the right position, but that doesn't, you wouldn't actually induce it while it's in the wrong position. Prolapse umbilical cord, I hope that one's self-explanatory. The one that's always tested is genital herpes. You can have genital herpes and still deliver vaginally, but you can't have an active genital herpes infection. Genital herpes is a torch infection, and it's almost always contracted during delivery, and the herpes actually gets into the baby's eyes and can cause encephalitis, herpes encephalitis, and among other things, and blindness, and all these problems. Herpes is a torch infection. It's why we don't deliver vaginally. It is an absolute indication for cesarean section if the mother has an active genital herpes infection. And of course, the other thing is uterine muscle incision. Now, this is important. Basically, if they've had a C-section before, you don't deliver vaginally. Now, there are some catches on this, and this is one of those another ones. Oh, I know somebody who did blah, blah, blah. The recommendation is that you do not, once you've done cesarean, that you continue to do cesareans on subsequent deliveries. Now, there are two different types of cesareans. There's the vertical incision, which is literally from the belly button down to the pubis symphysis. A vertical incision, that one is an absolute no. There's no way you can ever deliver vaginally again for the risk of rupture of the uterus itself. Then there's the low transverse incision, which in some scenarios they could be delivered vaginally, but across the board, it's almost pretty much, and always a recommendation, if you delivered cesarean, you always do cesarean after that, or any kind of a surgery through the uterine wall. You can have abdominal surgeries. Maybe you had your appendix out. Fine, that's fine. But a uterine incision, a uterine muscle incision, is going to be that the no-no. And of course, anybody who's actively hemorrhaging, we're not going to do that. Now, the next thing that's super important is getting the difference between placenta previa and abruptio placentae. These are two things that are really commonly compared and contrasted, and a great question for question writers. So placenta previa, I always remember that placenta previa is pretty much it's kind of passive. Placenta previa. There's placenta previa P. It's all P's. It's kind of passive. And I think of it as a passive. That doesn't mean it's not serious, but that means it's painless. And the placenta just kind of comes down, and it's probably because the placenta is in an improper implantation position, and it's covering that cervical opening. So what happens is as the cervix starts to dilate, actually causes painless bleeding and a bright red bleeding. So it's painless, bright red bleeding. Classic question you're going to see. But the mother themselves, they present, they're 36 weeks, 37 weeks, 38 weeks, and they have this painless, bright red bleeding. You should suspect placenta previa. Now, the other one is abruptio placentae. Abruptio placentae, remember, abruptio placentae is abrupt, and that's essentially a tearing, a pulling off of the placenta from the uterine wall, and it's very painful. There's several different classifications of it. We're not going to go into those, but just remember that it's this painful, very painful, and it may or may not have bleeding at all. But it's definitely going to be very painful, and you're going to have a very rigid uterus. It's going to be very painful because they're going to be, it's going to be contraction, and it's just pulling of the placenta off the uterine wall. So it's super painful, really important. they may or may not have bleeding, because it could be at the top of the uterus and it's ripped off from the top or from the side, and it's loculated up there. So they could be hemorrhaging, you don't even know it, but the pain is the important thing. Now, the other one that's super important, and you're going to see a lot of high-yield things for this, and that's ectopic pregnancy. Now, we talked about, in the beginning, the phases, and we talked about the proliferative phase of the menstrual cycle, where the egg gets matured, it releases, it ovulates, breaks free from the ovary, and it needs to be caught by the fimbriae of the fallopian tube, and then kind of be ferned in and come down into the fallopian tube itself, where it can then travel down. It's viable for 5 to 7 days to be fertilized. Now, what's really important is there's all kinds of abnormal fertilization. If it gets fertilized while it's still in the fallopian tube, and then it implants in the fallopian tube, it gets very big, and it can't expand. The fallopian tube is not a muscle per se. It's not a muscle the same way. It can't enlarge in size like the uterus. So what happens is, you can have an ectopic pregnancy, and then you can have a ruptured ectopic pregnancy. So if an ectopic pregnancy ruptures, that's going to cause severe hemorrhage and a shock scenario. And it may or may not be in the fallopian tube. That's the most common place, but it also could be inside of the abdomen somewhere. So there's different things for it, but the big thing is be able to identify a patient with amenorrhea. They've missed a period, and they have severe abdominal pain, and they're within childbearing years. One of the things on your list you should be thinking about is an ectopic pregnancy. If they're having shock-like symptoms, then that's really serious. If they have shock and a vaginal bleeding, and they're not pregnant, but they've missed a period, that's serious. That's probably an ectopic pregnancy, and they're getting a quick ride to surgery. So, we got our little characters in here. Let me just click through there. Oh, maybe not. There we go. So with ectopic pregnancy, a couple of different things. What do we need to think about it? Well, we need to make sure one of the things we give for ectopic pregnancy is methotrexate. Interesting one. Methotrexate is indicated, and when I talked about when they're going to surgery, if you catch it early on, a small ectopic pregnancy can actually be treated with methotrexate. Methotrexate is a chemotherapy. I mean, it's a cancer medication, right? And it's essentially going to kill the dividing cells, and then the body will evacuate it out and abort it, and process breakdown and metabolize it. If it's larger than 5 centimeters, I think is the number off the top of my head, then it's definitely an indication for surgery. And of course, if the patient has ever had if they're at risk, then you need to give them RhoGAM for a risk of transfusion reactions. We've got our little moth with that T-Rexate here, and for methotrexate, and our little surgeon guy, and our rowing groom to help you remember some of these characters inside of our ectopic pregnancy Picmonic, which is a one about Jurassic. It's a Jurassic Park, or it's a dinosaur one. Picmonic. It's super fun about characters. So a couple other things here are complications for pregnancy. So there's several different complications of things that you need to know. You really need to be able to identify a couple of these and know the numbers. And then we'll talk about diabetic and cardiac patients just really quick. So just really quick on the preeclampsia, and I need to update this slide just a little bit, but preeclampsia. Now, we talked about that 20-week number again. It just keeps popping up and creeping back up on us, and that's important. Preeclampsia is super important. It's going to see a lot of questions on this in OB land, and it's essentially hypertension. So proteinuria is not a requirement for diagnosis anymore of preeclampsia. So the 1+ and 3+ proteinuria are older classifications. So that's why I said I need to update this a little bit. But the preeclampsia itself, you need to remember hypertension. Hypertension is super important, and that's hypertension that wasn't there before pregnancy. So before the patient was pregnant, they were not hypertensive. But then they have this hypertension that's above 140/90. That's going to be basically early or mild preeclampsia. Severe preeclampsia, is essentially just severe hypertension. So it's above 160. Very serious. They often have proteinuria, but you're going to maybe even see oliguria, so an absence of urine. because of the hypertensive state. But what you will see, the number one thing you got to remember is this HELP syndrome. It's kind of a HELP syndrome can happen all by itself, absent of proteinuria and the hypertension. But you need to be identify these the symptoms. They're going to give you some patient scenario where you're going to see these elevated liver enzymes and thrombocytopenia for low platelets. So here we've got our hemolysis, elevated liver enzymes, and low platelets. So if you see somebody who comes in, they have these elevated liver enzymes, so AST and ALT liver enzymes, and then they have a thrombocytopenia and they're pregnant, that's HELP syndrome. That's serious, and they need some immediate treatment. They probably have hypertension along with it. Now, preeclampsia becomes eclampsia in one condition. What is the one condition that preeclampsia becomes eclampsia? What is the one thing that says preeclampsia to eclampsia? Seizures, right? That's the big one where we move on. So what is the treatment for preeclampsia itself before we get to the seizures? Well, bed rest. Magnesium sulfate's the big one. Magnesium sulfate's a big one to help calm that uterus down, essentially. But what happens? What do we believe is the cause of preeclampsia? Well, it's something that's kind of debated, and I don't know that it's 110% like guaranteed, but it's believed to be because of a decreased amount of blood flow to the actual placenta that's perceived as a decreased blood flow to the placenta. So therefore, the mother's body increases the blood pressure to be able to try to push more blood flow to the placenta. And there's some, believed predispositions to that as well. But of course, we're going to give antihypertensive for the hypertension. Super important to remember that these antihypertensives, you can't just go given any hypertensives because they're a risk, they're counterindicated in pregnancy. But the big ones are methyl-dopa, alpha-methyl-dopa is another way it's called, and labetalol. So really two important ones. And of course, the only true treatment for preeclampsia or eclampsia, the only definitive treatment, seriously, you're going to see that question, is delivering the fetus. That's the only way to stop what's going on, is to get to remove the fetus and the placenta. Now here's where we're talking about eclampsia. It's basically everything we talked about before plus seizures. So pretty much everything goes crazy. You're going to see increased reflexes. But the big one is you're going to see a hypertensive woman with a seizure. She ends up having a seizure, or she's preeclamptic, and you're not treating it well enough, or it's not getting treated. Then she has a seizure. Now it's eclampsia, and they need immediate IV magnesium sulfate to be able to control that seizure and then get the blood pressure under control secondly. Now, the next thing, diabetes, just a couple things to say about this, to really think about this, and there's a couple high yield points. But the insulin needs of the fetus and the levels in the body and the pregnant woman change. But what's really important is that almost all diabetic medications are contraindicated in pregnancy, except for a few. The couple big ones are insulin. Insulin itself is okay in pregnancy because that's mimicking what we have in our bodies now. And glyburide is another one that's okay in pregnancy, especially in the first trimester. Now, if you had a woman who's already diabetic, this is somebody who's already diabetic and then they get pregnant. This is not gestational diabetes, even though it's similarly treated. But if you have somebody who's already diabetic and they get pregnant, you need to switch their medication. So you would, they would need to be put on insulin, and then they need, maybe glyburide. Metformin and the other ones that are out there, all those other diabetic medications are not recommended in pregnancy. And a lot of these medications, some of them aren't recommended because we don't have any way to test them. It's very unethical to test pregnant women and give them medication because that's just unethical treatment. So, but with this, it's important to remember that in the second trimester, as the baby is growing, right, the baby is growing the most in the second trimester, that the insulin needs are at the highest. So insulin doses would need to be increased during the second trimester to be able to control the blood glucose down into a normal range. It's also important to remember that that's in the second trimester is when we check our patients for gestational diabetes. So we're checking them for gestational diabetes with that glucose load to see, because all the insulin needs essentially are the highest thing. Oh, it looks like I need to charge my computer here. There we go. My battery's going to go dead. That's not good. But anyway, the other thing in diabetes, just remember it's super important you get the complication of macrosomia. Macrosomia is a very common thing in diabetes that we can see with a woman who has diabetes, as we see diabetes. You see this enlarged baby, a large baby that's over 4,000 grams. That's going to be macrosomia, large baby, and that's because of the high amount of glucose that's there. Because the baby, if there's lots of sugar, baby's going to get a little fat. Just like if you send in all those cookies and I eat them, then I would get fat, but send them anyway because I'll share with my friends. So we've got our other characters here, some more characters from our Picmonic. Now, if you have a cardiac patient that becomes pregnant or that is pregnant, there's a couple of important things to be able to monitor and understand. And the important thing here is is knowing that the blood plasma volume itself increases. Now we talked about this. We talked about this already with having the. Let me get my little charger plugged in so my battery doesn't go dead. Is to know the blood plasma volume increases. So it may be as much as 50%. So the heart gets bigger to be able to pump all this blood around, and that's super important. So if my heart is already stressed because I have cardiac myopathy or if I've had a history of cardiac MIs, then my heart has to work harder when I'm pregnant. So I'm going to need to take it easy. I maybe need closer monitoring and things like that. Super important. Now, prenatal needs, of course, always need to be really important in a cardiac patient or in any patient because of that increased plasma volume, because of that risk of this transient anemia. So if we increase the plasma volume, then I'm not going to have the same number of RBCs per liter, so therefore I need to make more red blood cells. And that requires iron to make red blood cells because you need that to be able to synthesize red blood cells. And of course, our folic acid is good as well because that folic acid helps us synthesize DNA. Let's see here. Oh, we got a lot of characters popping in again. So of course, other things to be able to, specifically with a cardiac patient, you really want to make sure that they're not straining and not increasing that intra-abdominal pressure because it's going to cause that risk for hypotension because of the increased pressure on the superior vena cava, the vena cava. And then we're going to give them, we would switch any kind of antihypertensives usually to calcium channel blockers and just monitor them very closely as well. So prophylactic penicillin is sometimes also given too, but not always indicated. And that's going to be given for risk of infection and whatnot. Now, the last thing we're going to talk about here is some neonatal assessments. I'm trying to, some of my questions aren't coming in. So somebody asked really quick about antihypertensives being harmful to fetus, and that's yes. There's only a few antihypertensives that can be given during pregnancy. Calcium channel blockers are one of those, and as well as alpha-methyl-dopa and labetalol because it's a alpha and beta blocker. That one's a really good one. But you would avoid ACE inhibitors and angiotensin receptor blockers. Now, they can be given, but they're avoided because just the risk of renin-angiotensin system and causing severe effects and decreased blood flow to the placenta. So neonatal assessments, I'm just going to talk a few things about a couple of these because there's some high yield points in with these that you really need to know. The biggest one is being able to calculate the beautiful APGAR score. Now, I love our little APGAR Picmonic. I hope I put my little, oh no I didn't. Oh, dag on it. Anyway, we've got in our side of our little Picmonic, we got all the little babies here to help you remember everything for APGAR. So we have appearance, pulse, grimace, activity, and then respirations in here for APGAR to help you remember all of them. Excuse me. But of course, then it's a scoring system, so you need to know how to score each one. So it's a 0, a 1, or a 2, and you know that you need to have a good APGAR score, which indicates that you have the appropriate amount of a good healthy baby, as we'll call it. But as we're looking at vitals, we need to, sorry, got a fuzz or a stitch hair in here. We look at vitals. We need to know the normal heart rate should be anywhere from 110 to 160. Super important. Respiration is really, really fast. And other things that are going to be done as soon as that baby is born is they're going to be measuring the head. They're measuring that head circumference because that's going to allow us to also monitor that baby for hydrocephalus and other things to make sure we're tracking that head circumference along. They're going to check to make sure that the fontanelle is open and soft. It's also something you're going to be doing. And then immediately getting weighed and measured. Now, remember what we said about that weight. We know that the weight, the average of good weights, that 3,200 grams. If we go over 4,000, that's our macrosomia, that's our big giant baby. And of course, length can vary as well. And then getting the normal temperature. But the other three things are super important. You're going to inspect the umbilical cord. The umbilical cord needs to have 2 arteries and 1 vein. What does it mean if it doesn't? Is it a problem if it only has 1 artery and 1 vein? I mean, is it like a red alert right there? The answer is no. But it is going to indicate to you that there has been some kind of fetal anomaly here, and it's going to put you at a higher alert to look around or be aware that there may be other problems. Because there could be a potential for decreased blood flow, which could have then caused other detrimental effects, or could be because of a chromosomal abnormality or whatnot. The last thing, just because they're going to check for a patent anus to make sure that they do actually have a patent anus, and then they're going to check for hip abduction and adduction. So they're going to flex the hips and then pull the hips in, and they're looking for clicking. To see if there are any kind of abnormalities there with skeletal development. So some other terms that are super important that you're going to see. I always found these really confusing, so I put them in here. Vernix caseosa, so vernix. Baby's born. Baby looks like he's covered in white cheese. Baby looks like he's got a white film all over him. Looks like his skin's peeling off. That's perfectly normal. That's vernix caseosa or vernix. It is normal. It will come off. That's why when they're born, you're going to see maybe you've not done your OB or you've seen this in your rotation, but they're pretty vigorously scrubbing the baby to try to just clean them off. And that's all the vernix on there. Some women have develop more than others, or babies have more than others. It's just kind of like having hair on their head when they're born. Some have more than others. Lanugo itself, kind of another one that can vary, but it's a little, it's peach fuzz, essentially. So I didn't hit puberty till I was 20, I feel like, but up until like 18 to 20, I had peach fuzz on my face, little tiny fine hair, only it covers the whole body. It's lanugo, it's a really fine hair. Again, some babies have more than others, but that's another normal finding as well. And of course, the other thing that you'll see very often thrown in there, or you see a picture of it, and that's caput succedem. I can't even say it today, but caput succedem, and it's basically the swelling of the scalp. And is that normal? Yes, it's normal because you basically the baby is squeezed through the vaginal canal, and basically that's a lot of trauma going smashing your head through a small space. That's why the fontanelle is there, so it can go through, and you can see some swelling on the actual scalp, or if there's a suction device used, which can be used sometimes to be able to pull the baby out to assist with delivery, you can see even basically like a hickey almost appear on the scalp. So those are all normal. Some other things, as far as hemorrhaging, there's a lot of blood flow or fluid that's lost during pregnancy. Not a whole lot, but enough to where it looks like it's a lot. But it's really important that the number one thing you'd be aware of is postpartum hemorrhage. So of course you're going to see the blood flow, but the number one thing you're going to see is you're going to palpate that uterus, and it's going to feel like a soft pillow in there, and that's not what it should feel like. But that's one of the reasons why you can have hemorrhaging. So you're going to massage the uterus. The uterus itself can just maybe it ruptured. Maybe it has no it's uterine atony. It's called. There's no muscle tone. That's another reason for hemorrhage. So how do we do? We would stimulate. We do a fundal massage, so a vigorous stimulation of the uterus to get it to contract down. And as it contracts, then it squeezes off and pinches off those blood vessels, and essentially then decreases the blood flow. The other medication that we can give is oxytocin as well. Our little octopus toe character. So as we are looking at our postpartum assessment, as we're looking be able to assess our post-birth assessment, essentially, the little acronym of Bubble LE is good. And essentially, you just want to look through all the body systems. I'm not going to go through each one of these just for the sake of time, but you're basically looking at all the systems to be able to make sure that they have evacuated their bladder, that they're, what is their lochia? Are they having vaginal discharge? Look at their legs, make sure that they, any of the incisions, everything's draining properly. It's a really good one. We got a good Picmonic. You can go check this out. But also most importantly, it's just making sure that the lady's not breaking down. Now, the last topic I want to talk about, I think it's the last one, is Sheehan syndrome. Sheehan syndrome is super important. It's often forgotten, but you're going to see this a lot creep up in questions. And what happens is when you have, especially if you have usually a female who has postpartum hemorrhage, so they've lost a lot of blood flow. Now, remember that in pregnancy, the plasma volume increases 50%, so that fluid volume increases 50%, right? So that's a lot of extra blood flow. So what happens is the pituitary gland actually enlarges as well. So the tissue in the pituitary gland at the base of the brain enlarges to be able to keep all these hormones going okay. And what happens is if you bleed a lot, you lose a lot of hemorrhage. Then what happens is the pituitary gland, there's maybe not enough fluid volume to keep the pituitary okay, and it actually infarcts. So the tissue dies because of a lack of blood flow. And what happens is then without a pituitary, you end up with literally a lack of all hormones. All the way across the board, no hormones per se. And what happens is, because of this, you end up with usually the scenario is a woman who had a hemorrhage and now she has hypothyroidism and she can't breastfeed and she hasn't had a period and she pretty much you should be thinking or suspecting Sheehan syndrome or a pituitary infarct. So they're going to pretty much need supplemental hormones for the rest of their life for this. But it's a common question that pops up classically with that the hemorrhage, postpartum hemorrhage, and they're going to ask you, they're going to give you some signs and symptoms, and they ask you what happened. It's pituitary necrosis because of a decreased blood flow. Oh, I do have just the last one. Actually, this is my favorite Picmonic ever. If you never saw a Picmonic, go in, listen to the breastfeeding Picmonic, and play the story audio. It's the breastfeeding rap. I play it all the time, and everyone at the office hates me for it, but it's a fun rap song. But it's important we always encourage breastfeeding for several different reasons. But remember that breast milk itself is a couple important things. It has all the nutritional factors that a baby needs, except vitamin D. But it also, when you breastfeed, you actually are passing antibodies. So you're giving this immunity to the baby of all the antibodies passing through, and that's super important for early on immunity. It's something that breast milk's not going to have. But also just they believe about there's some cognitive development and health risk decreases because of antibody protection and whatnot. So it's also believed that SIDS risk is reduced, sudden infant death syndrome as well. So with SIDS, again, it's really important to make sure that the back is on the bed whenever the baby is placed to sleep, back to bed for SIDS reduction. It's another really common question that's out there. So not to throw off another tangent, but whatnot. Okay, that's it. We appreciate you joining in and checking out the webinar. It's really it'd be nice if you would look at those videos right there and watch some of the videos, or definitely subscribe to the channel. Actually, it's right there. There's a little button. Just click on it and subscribe to the channel. And we appreciate you joining in today. And as always, good luck studying.